Okay, so yeah, most of you guys are pretty involved in ECMO already, so a lot of this is going to be review, but I wanted to just touch on some of the practical things, the caveats that I see in ECMO that I think are beneficial to point out and remind people from time to time. So VV ECMO and VA ECMO are going to be really similar for the most part, but they're not exactly the same thing, right? They both have the same fundamentals. They have cannulas, they have a pump, they have an oxygenator, they have blood moving from one place to another, but they're not quite the same thing. So where's my Diet Coke drinkers? Is Diet Pepsi the same thing? It's not the same thing, right? But they both have carbonation and they both have caramel color and aspartame, you know, so for some people they're interchangeable and they don't quite understand the fine point differences like us true Diet Coke drinkers do, even though I've been off of it for a while. But VV and VA ECMO, they're not the exact same thing. There's a lot of fine points, and it's up to us as perfusionists and ECMO specialists to continue to remind our providers and our residents and our nursing staff about those small differences. So these are the indications for ECMO that ELSO has listed. ELSO is a fantastic resource. If you have the red book, if you go to their website, if you look up there's PDFs of all sorts of things online. ELSO is a great resource. But these are recommendations for use that I have listed here for VV and VA, and you're going to see ECMO used for lots of different reasons in your facilities and in your ECMO programs. Most of the things will fall under these categories. Some of them are going to be combinations of these categories. But ECMO, in itself, doesn't fix anything. What it's going to do is it's going to buy us time for that patient to heal, for that patient to recover, whether it's lung function or cardiac function or a mix of the two, or it's going to buy us time to make another decision and funnel that patient into a durable VAD, a transplant, something else down the line. So ECMO is not going to fix anything, but it's going to buy us time so that we can maybe get that problem fixed or corrected in another way. So veno ECMO, when I was a young perfusionist, veno ECMO, it was in the textbook. Nobody was really doing it. Early in my career, VA ECMO was usually a last resort. It's what they did for kids, you know. So for adults, it was our last ditch effort if we couldn't get somebody off pump. But over the years, ECMO has expanded, and VV ECMO probably is equally as common, if not more common, than VA these days. So as technology improved and ECMO expanded, we got some better equipment, we got some new cannulas that enabled VV ECMO to really take off. And once we started using VV ECMO more, we got better at ECMO in general. All of the ECMO seemed to gel and get better. Somebody touched on this yesterday, but it was the 2009 H1N1 flu epidemic that really helped jumpstart ECMO to the forefront. So that kind of coincided with us getting the polymethylpentene oxygenator membranes in the Quadrox, and it coincided with the dual lumen neck cannulas. Those all came out around the same time. So that year, 2009, ECMO was everywhere. You couldn't get a rental or a loaner pump. They were all in use somewhere. Everybody had max number of patients on for a short time. And just thereafter, the literature exploded. There were a ton of publications. We realized that we had been excluding some patients previously that could really benefit from ECMO, so we started to include them in our criteria and support them with ECMO with success. So, you know, we refined our circuits, we refined our techniques, We simplified cannulation, results improved, and ECMO just continues to grow and grow and grow. So this year with COVID-19, I think we're going to see a similar phenomenon. There's some new products out on the market currently. There's more new products coming out soon. We're supporting patients that we would have excluded before, and we're having success with it. So ECMO is just going to keep growing and growing and growing. Look in the next 6 months for publications, and I think you're going to see a lot, just like we did back in 2009. So for us, that's all good, right? That's job security. There's plenty of ECMO for us to do. So the pathophysiology, Bill talked a lot about this, but somebody once described VV ECMO to me as adding IV oxygen, and I thought that was a brilliant simplification. I find that there's sometimes confusion amongst providers, and it's sometimes the nursing staff, sometimes the residents, sometimes the intensivists. You know, they kind of mix up, are we on VV or are we on VA? And they don't understand the finer things that go along with each of those modalities. So it's up to us to kind of keep them straight and keep them on the right track. So VV ECMO, we're just replacing lung function. So there's not any hemodynamic support other than what comes along with what comes along with stabilizing the patient's oxygenation. So you're not going to always see 100% saturation, like Bill pointed out, and that's due to mixing. So if we are able to achieve 4 to 5 liters of flow with our ECMO pump, but the patient's cardiac output is higher than that, then we are not oxygenating 100% of their cardiac output. We're going to have some mixing. We know from the congenital heart kids, they live their lives, their whole lives that way. You know, they live at a saturation of 80, 85%. So we know it's safe. We know it's okay. So achieving 100% saturation on VV ECMO isn't really necessary. Like Bill pointed out before, we're not necessarily hypoxic as long as we know what to look for to ensure that we're supporting our patient adequately. So what are we going to look at? We're going to look at blood gases, right? We're going to look at the lactate levels. We're going to look at our base deficits. We're going to look at the big picture of the patient. How are they doing? How are they looking? If the lactate levels are stable and the saturation is good enough, we're going to accept it. So adequate tissue perfusion will ensure that you have enough support going to your patient. Sorry guys, I'm not as poised of a speaker as these guys, but that's okay. So yeah, if we look at the big picture of how the patient's doing and check our lactates, check our blood gases, we'll know that we're adequately supporting our patient. Cannulation for VV ECMO. Basically, we have two choices. We have the 2 cannula module, where you're draining from one cannula and reinfusing in another cannula. And usually we see that as femoral to IJ. So with the return being in the IJ so that it's in close proximity to the heart, you want to get that oxygenated blood as close to the heart as possible so the heart can pump it out to the body, right? So sizing and placement are important, and if the size of your cannula or the placement of the cannula is incorrect, that can be kind of difficult to overcome. So the last thing you want to do is get on ECMO and then call the surgeon back and tell them that you need to put a bigger cannula or they need to move a cannula. They're not going to be very happy, right? So we try to choose our cannulas carefully, plan out our ECMO if possible, and do that work ahead of time. Sometimes I've seen 2 surgeons work together on the 2 cannula access. One will do the IJ while the other one does the femoral, and really you can get on ECMO very quickly if they take that approach. The dual lumen cannula, I think, is a brilliant invention. So you have the Avalon by McKay and you have the Crescent by Medtronic, and I've used them both. They're both great. I can't say one's better than the other. You guys are going to choose whatever you want at your center. But placement can be just a little tricky. Not only does the insertion depth have to be correct, but the outflow has to be pointed right at the tricuspid valve. So the rotation in comparison with the patient's anatomy has to be pretty spot on. So it's recommended to place this with fluoro or with TEE guidance so that you can make sure that you're in the right place. But this cannula offers us a lot of options when it comes to mobilizing the patients. So they showed some videos earlier in the conference about patients doing the exercise bike with femoral cannulas, and that kind of gives me heart palpitations. But hey, if they're doing it, more power to them. But I would rather do it with a neck cannula if I have my choice. So both types of cannulas really need to be secured well, though. So you have to check your cannula regularly and make sure that it's not migrated. Moving patients, I think whether it's a small bed change, you know, sometimes we just turn and rotate, or it could be going to CT scan, or it could be walking them up and down the hall. Securing your circuit, securing your cannula, making sure everything is free and mobile and you can visualize it. That's what's important to me as the perfusionist, and what I think you guys should take away. You know, make sure you can see everything, access everything, check everything regularly to make sure that there's no problems with it. And that way your ECMO circuit and your cannula will stay intact. So a complication that you're only going to see on VV ECMO is recirculation. You can't have this on VA ECMO, right? So recirculation happens because we're taking blood out of the venous system and putting it back into the venous system. We're in the same side of circulation. So if the cannula placement is incorrect, if the cannulas are too close together, or if your double lumen cannula is not pointed at tricuspid valve, you can have your oxygenated blood exit your pump and oxygenator and come right back into your venous cannula. And so then your patient's not getting the true benefit of ECMO. So how do we diagnose this? Anybody know? We're going to look at a pre-oxygenator blood gas. Or if you have CardioHelp or that new fancy Medtronic oxygenator I was looking at, they will give you the numbers on a screen right for you. But if your saturation in the venous blood coming into the oxygenator is higher than you would expect it to be, you might suspect some recirculation. I think there's almost always going to be some degree of recirculation and in your VV ECMO, but how much we tolerate is gonna depend on what we want to do about it. If the surgeon's available to come back and move the cannula, more power to them. If we have to wait till he comes out of the OR to do so, we might have to wait a little while. If you turn your pump flow up when you think you have recirculation, it's probably going to get worse, right? Because the velocity of that blood coming out of the oxygenator is going to come right back to your venous cannula. If you turn your pump flow down a little bit, you might see that recirculation lessen because you're slowing down the velocity of the blood coming out of the reinfusion cannula. So that's another way that you can diagnose if you have recirculation or not. And the way to fix it is to move the cannula. So you're going to need your intensivist or your surgeon's help to do that. Bleeding complications. The number one complication in ECMO is bleeding, isn't it? It's universal. It happens everywhere. Every place, every ECMO has some degree of bleeding. We're going to balance bleeding and clotting and manage anticoagulation in VV ECMO the same as we do in VA. I often see providers want to minimize anticoagulation in VV, and the reasons that they'll cite is, you know, because we're working in the venous side, they're not quite as concerned with embolic risk as they are in the arterial side. These patients may be trauma patients. They may have had another surgical procedure. Usually there's a lot going on. You know, there might be some other reason that they've developed ARDS and need to go on ECMO. And the surgeons are going to always want minimal anticoagulation. We, as the ECMO specialists and perfusionists, we're thinking in terms of circuit preservation, right? So we're going to want as much anticoagulation as we can reasonably have. So I'm thinking about circuit preservation, and if we're going to be on ECMO for a long time, I want to change as few components as possible during that ECMO run, and I want to preserve my circuit at all costs. So we're going to tolerate some clot burden in the oxygenator. And you guys, you look with your little flashlight, right? And you look at the inlet side of your oxygenator and you see that clot and you see it progress from day to day to day. It's less concerning if it's on the inlet side, right? If it's on the outlet side, then it becomes embolic risk. So if it's on the inlet side, it's got to filter through that, the membrane itself to become an emboli. So I hear a lot of docs say, well, we can have a little bit on the outlet side because we're on VV, right? Well, what if that patient has a PFO that I didn't know about and I let a moderate amount of clot build up on my oxygenator outlet side? Well, that's not okay with me. You know, I think it's better to practice more cleanly. Any clot on the outlet side is always concerning. Any clot burden in the oxygenator is always concerning. Communication with the rest of your team in making those decisions on when to change an oxygenator or when you need to make an intervention is going to provide us the best possible outcomes for our ECMO patients. So, emergent circuit issues. If we have a circuit emergency on VV ECMO, generally we have a little bit more leeway and a little bit more time to deal with it than we do on VA ECMO. Not in all cases, but in a lot of cases. So if any of you guys know me, you know I'm all about backup plans, right? So loss of ECMO support, whether it's temporary or complete, can really devastate your patient. So circuit interventions need to be planned. They need to be well thought out. You need to have supplies and help and everything lined up ahead of time if you can. So if you're going to come off to change a pigtail versus change an oxygenator or change a circuit, you know about how long that's going to take you and what the repercussions are going to be on the patient. Can that patient tolerate to be off ECMO for 60 seconds for an oxygenator change? What if it's going to be 2 minutes because I'm not so fast at it? Can they tolerate it? So the nature of your circuit loss is also going to play in there. If you have an emergent circuit issue, most likely you're going to be concerned with your circuit, right? You're going to be diagnosing what's going on in your circuit. But somebody has to say, hey, we need to go to emergency vent settings. And a lot of times it's the perfusionist that's going to shout that out first and remind the nursing staff and the other folks in ICU, hey, we need emergency vent settings. I've got a problem with my circuit and it's going to take me X number of minutes, I think, to fix it. But knowing where your supplies are, do I have a backup circuit? Is it wet? Is it dry? How long is it going to take me to change it? How long is it going to take me to change it if I have to prime one fresh? You know, those are the things that I think about whenever I go into an ECMO shift. Where's my clamps? Who's the intensivist? Do I have his number close by? Is there another perfusionist in-house that I'm going to be able to call on should I have an issue during the next 12 hours? Those are all of the things that I like to think about and plan out before an ECMO shift. And also, if you have a patient that codes on VV ECMO, you respond a little differently than on VA, right? So VV ECMO is just providing oxygen and ventilation. We're not providing any hemodynamic support. So if you lose your patient's rhythm on VV ECMO, what are you going to do? You're going to follow ACLS. Somebody might need to start chest compressions. You may need to call the surgeon and recannulate to VA ECMO if you don't get them back. So the backup plans for each modality are a little bit different. Weaning from VV ECMO. So weaning can take place over short periods of time, long periods of time. Sometimes as soon as you get on, you start talking about weaning. Weaning is my favorite part of ECMO, by the way. But sometimes it can be confusing from VA to VV. So weaning VV ECMO, I think it's best to wean by gas flow and not pump flow. There's no reason to turn your pump flow down because you're just shunting. You're just shunting. Unless there's a trajectory into your RV that's causing some RV failure, right, Bill? But you're just shunting blood, so you can stay on full flow It's protective to your circuit, especially if they want to pare down your anticoagulation to get ready for decannulation, right? So it's protective for your circuit to keep the blood flow as high as it was. But you can wean down your gas flow. And you'll get a more steady linear progression if you leave your pump flow the same and wean your gas flow. If you change both at the same time, you're going to get a less than linear progression because you're going to have residence time in your oxygenator at a longer or shorter period of time depending on your blood flow ratio. And you'll know that you have success by your blood gas results, right? Just like when we knew we were supporting our patient adequately, we know we're weaning successfully if the lactates aren't bumping up, if we're not building base deficits. If our patient's blood gas looks okay and the ventilator settings are still reasonable, we can wean ECMO. So, veno-arterial ECMO. Veno-arterial ECMO always seems a little bit more intense than veno-venous ECMO. And it's more similar to cardiopulmonary bypass in that we're draining out of the venous side. We are truly bypassing the heart and the lungs, and we're pumping back into the arterial side. So we are providing cardiac support, but subsequently we're providing respiratory support too. And a lot of times our VA ECMO patients, we go on for cardiac reasons, but in the events that lead up to ECMO or in the beginning of stabilizing on ECMO, we tend to fluid overload them, and you'll see their chest x-ray white out the next day. So sometimes we go on VA ECMO for cardiac reasons, but we stay on a little longer for respiratory reasons. So pathophysiology, Bill covered a lot of that, but we may be providing near total or total cardiac output for our patients on VA ECMO, depending on what their current cardiac function is. So the more work the ECMO is doing, the flatter your pulse trace is going to be on your art line, right? So we would like to see the ventricles unloaded so it reduces their workload and the myocardium can rest and recover. We'd like to keep a little bit of blood flow through the left ventricular outflow tract and the aortic valve so that we don't have stasis of that blood and it doesn't clot. An LVOT clot can be pretty detrimental on ECMO. And if the ventricle remains distended, then the heart can't really rest and heal because it's going to increase the workload of the muscle in the myocardium. So there's a couple things you can do about that. If you have incomplete emptying of the LV, you can put a vent in. A surgical vent works pretty well, and you can Y it into your venous line so it'll passively drain back into the pump. Or what's commonly done in most places is they add an impella. So you're on ECMO with an impella. And the impella needs to just flow minimally, but it'll just keep that blood moving through the LVOT. You want to make sure your aortic valve is opening and closing, if at all possible, to keep that LVOT thrombus free and the ventricle nice and decompressed. So how do we know we're providing enough support on VA ECMO? The same as on VV ECMO, right? We're going to look at our lactate levels, we're going to look at our blood gas. That part's going to be pretty universal. We may need a little bit of SVR support when we're on VA ECMO, but typically we should see our inotrope needs go down to almost zero if possible. A lot of times you can wean the inotropes off, but a little bit of SVR support is sometimes necessary. So yeah, the pump flow can contribute significantly to the patient's MAP, but it's not always perfect. Cannulation strategies for VA. These are going to be dictated by the patient, really, and sometimes how fast you need to get on ECMO. So if the chest is already open, if they are failure to wean from bypass, or they're a post-cardiotomy patient and their chest had been opened recently, sometimes that's the fastest route to get on ECMO is to go central cannulation from the right atrium to the ascending aorta. But closing the chest is desirable, right? Because we don't need as much sedation. It's less infection risk. We can let our patients move around a little bit if their chest is closed. So femoral cannulation or peripheral cannulation is what we see more often. You might see some creative cannulation in VA ECMO, and it's more like an RVAD with an oxygenator in the circuit or an LVAD with an oxygenator in the circuit. It's not quite the same thing as VA ECMO, but it's still ECMO, and you're still probably going to be responsible for that circuit and take care of it. Your perfusionists and ECMO specialists are still going to be involved if there's an oxygenator anywhere in the circuit. Bigger vessels are better. So for adults, usually femoral is it. Sometimes in babies, they will use the neck vessels because in neonates and infants, the neck vessels are larger than the femoral vessels, right? But femoral artery is a pretty good source for your ECMO cannulation. I usually ask for the largest cannula that I can get, right? I want the biggest one. The surgeon usually wants to put a smaller one, and I've got to talk him into letting me have a bigger one. Vascular volume status is going to play in, just like your VV ECMOs. So cannula placement, where your drainage is coming from, is equally as important. And we need to anticipate how much we need to flow when we're deciding on which cannulas to choose. So a complication that you'll see in VA ECMO that would be pretty rare to see in VV ECMO is distal limb malperfusion. So I've just asked the surgeon for the biggest cannula possible, right, to put in the femoral artery. So I could be blocking the flow down to the distal portion of the leg by putting that very, very large cannula in. So there's a lure port on almost all of the arterial cannulas right at the hub where the connector is. During cannulation, I always ask my surgeon to put a stopcock on that. And we can address this later if we need to. But if he puts the stopcock on when we cannulate, then we don't have to come off ECMO for a couple seconds to put a stopcock on there later. But usually they can just put a small angiocath, like a 5 French, it's pretty small, in the distal limb of the femoral artery below where the cannula is, and then just put a little piece of tubing, and it'll be enough flow to keep that leg well perfused and avoid complication while you're on VA ECMO. And a great thing to do to ensure that you're adequately perfusing that leg is if you have a cerebral oximeter, you guys use cerebral oximeter? Put a sensor on each calf. And it's not going to be quite as accurate a number like it is on the headset because there's going to be more adipose tissue and more tissue on the calf in general. But your goal is to get both legs to be roughly the same number or in the same ballpark at least. If your cannulated leg is significantly less than your non-cannulated leg, then you know you're missing out flow to that second leg. Harlequin Syndrome. Does everybody get confused when they start talking about Harlequin Syndrome? It's called North-South Syndrome. It's called differential oxygenation. But it seems like when anybody talks about Harlequin Syndrome at my hospital, like everybody's in an uproar. Do we have it? Do we think we have it? What's going on? But you're only going to see this on VA ECMO. You will not see this on VV ECMO. And typically you won't see it with central cannulation. If you're femoral cannulated, if you are peripherally cannulated, you're more likely to see Harlequin Syndrome. So the good news is to have Harlequin Syndrome, that means your cardiac function is returning, right? But the bad news is that the lungs are not in good shape or your ventilator just needs turned up. So if your ventilator just needs turned up and the lungs are capable, congratulations, you can wean ECMO probably, right? But if the lungs can't handle perfusing for the patient, then we need to do something about this. So to diagnose Harlequin Syndrome, if you turn your pump flow up, you're going to have your oxygenated blood exit the oxygenator, and it's going to meet where the blood flow from the LV is coming out of the arch somewhere in the thoracic aorta, right? So that mixing cloud can move north or south based on which one is stronger, the LV ejection or the pump flow. So if you turn your pump flow up, you can move that mixing cloud kind of north, And if you turn your pump flow down, you're going to move that mixing cloud south. Does everybody get that? Yeah. So if you draw a blood gas from your right upper extremity, it's going to be more indicative of what the patient's lungs and heart are providing as far as a PO2. If you draw from a femoral or a left extremity, it's going to be a little more indicative of what the oxygenator is putting out. So you can draw from those two sites and compare one against the other to decide if you have Harlequin syndrome. Bleeding back to it. It's always going to happen on ECMO, right? So we're still going to balance that clotting, bleeding, anticoagulation. The reasons I hear surgeons and intensivists cite that they want to minimize anticoagulation on VA ECMO are usually because that patient is post-cardiotomy and they're very coagulopathic, so they don't want to anticoagulate them. Or they've got a surgical incision and they're going to bleed from that surgical incision, so they don't want to anticoagulate them. But you know, us as perfusionists, again, we're thinking circuit preservation. I want to keep my oxygenator and keep my circuit in as good a shape and as usable for the longest period of time that I can. So, you know, anticoagulation is necessary. And a moderate amount of clot burden on the inlet side of the oxygenator can be tolerated as long as the oxygenator is functioning. And any clot burden on the outlet side of the oxygenator is an immediate embolic risk. And it's very, very important, right? That's going to necessitate an oxygenator change. So emergent circuit issues on VA ECMO, these can be really scary, right? Because your patient can hold their breath for a minute or two on VV ECMO, but you can't stop cardiac function for more than a couple seconds without detriment to your patient. So on VA ECMO, if you have immediate impacting circuit issues, you need to act very quickly. You need to have all of your supplies and all of your resources prepped and ready to go. So that's when you come into your ECMO shift, know where your resources are, know who's available to help you, know where your extra cannulas are, where's my extra circuit, where's my clamps. If you have an arrhythmia on VA ECMO, it's not the end of the world, right? It's inconvenient, it's you know, it's not nice to look at, but it's not immediately life-threatening. You can take a breath and plan out what you're going to do. I've had patients on ECMO that were asystolic before, and they're on VA ECMO. So yeah, it's not the end of the world if you have rhythm issues on VA ECMO. If you've been weaning and you come down and you have instability, all you've got to do is go back up on flow, right? Go back to full support. So weaning from VA ECMO is going to be by pump flow, not gas flow. How many times have you had a resident come over and want to take your gas line off your VA ECMO patient? I've had that happen before and had to say, no, this is VA. We are shunting from the venous side to the arterial side. We cannot take the gas flow all the way away. So it's going to be more like weaning from bypass. So as you reduce your pump flow, you're going to leave a little bit more blood in the patient's heart for ejection to their lungs and then to their body. The right heart's going to pump to the lungs, the left heart's going to pump to the body. You need adequate ventilation, right? So we have to remember to turn the ventilator back on, and as long as those settings are reasonable, we can go towards weaning ECMO. Sometimes you have to add inotropes into the mix, or maybe another support device like a balloon pump or an Impella. Some people are lucky enough to have a bridge in their circuit if they still have one, or they might cut one in for weaning, that you can keep your circuit flowing after you've weaned off, just to preserve it for a little while, to make sure that you're not going to need to go back on ECMO. But if you've just come off ECMO and then something happens and the surgeon wants to go right back on, where's your cannulas? Are they at the ECMO bedside, or are they all the way down in the pump room, right? Have all your things ready all the time. I can't stress that enough. But circuit checks and maintenance are what you're going to spend most of your time on ECMO doing. So somebody once said to me that ECMO is 95% boredom and 5% sheer terror, and there's nothing in between, right? So this is the 95% boredom part. So circuit checks and maintenance, you're going to get your little flashlight out, you're going to check your oxygenator for clot, you're going to check all your connectors, you're going to check your cannula, you're going to look at the dressing for oozing, you're going to do an assessment of every little inch of your circuit. And that includes your heater, cooler, and water circuit, that includes your gas flow circuit, make sure you're plugged into the appropriate outlets, all that sort of thing. I like checklists, so I like to do a shift change checklist so that when you come on shift, you can look for all of these resources and look for all of these supplies and make sure you have them available for your shift. And then anytime you move your patient, like if you take a trip to CT scan, if you have to take them for a walk up and down the hall, I like to go through that checklist again when we get back. So it's terrible if you get back from ECMO and you've forgotten to plug your pump back into the wall power and you've run your battery out, right? Has anybody ever seen that happen? I've seen it happen. So if you had a shift change checklist or a transport checklist, you can avoid some of those issues from happening. So I think overall with planning and diligence and the expertise of our perfusionists and ECMO specialists, we can achieve the best possible outcomes for both of our VV and VA ECMO patients.